So when Dr. Yahya asked me to present this topic, I don't claim to be expert in non-invasive high frequency. I think none of us are, because there's really not a standard way of ventilating babies. But I like to, since we have a small group discussion, I'm going to tell you a little bit story to start with. I'll take you back to, I'm going to give you exactly now my age. So 1996. So we're two fellows on the end of the night taking calls in the level 3 nurseries in Philadelphia. And one of them probably you'll know from the publication that came out afterwards. We talking about, it was not a busy night. So, I don't know if you know Temple University, it's like we get 10, 15 admissions at nights, or like walking out without prenatal care and all 25 weeks and stuff. So we're talking about how can we ventilate babies without putting in the ET tube? So it was like after midnight, we're hypoglycemic a little bit. We're getting intoxicated on Temple food. And it's like, and that other fellow is like, oh, can we just do nasal ventilation and put a ventilator on cycling mode? So we look at each other like this, and it's like, oh, we're crazy. And he's gonna perforate his abdomen. Bad things gonna happen. Ventilation have to be with the ET tube. That's in our mind in 1996. And we end that discussion, and everybody went into their own, practice. And my friend, actually, who was the other fellow, went ahead and, practiced this or did a study in Albert Einstein Medical Center in Philadelphia. And he published the first paper on NIV-PC. So all we also use NIV-PC, right? We do non-invasive ventilation. At that time, it was a crime like to do NIV-PC because nobody knew about NIV-PC. So if you go back to Journal Pediatrics, AAP journal, you see a paper, landmark paper by Dr. Muhammad Khalaf, who is the first one who described NIV-PC in the literature. So just my introduction. So how about NIV high frequency? We do a lot of non-invasive procedures since that time. We do non-invasive surfactant administration. We do NIV-PC, of course, like a standard of care. So why not NIV high frequency? So we go over my objectives for this next 20, 25 minutes. I'm going to introduce you to the high frequency. What's the difference in high frequency? Because when I talk to our fellows, we have a fellowship program, and not a lot of people understand the mechanics of the high frequency, how it works, and where they come from, and what's the difference between the different modes and stuff. So I'm going to introduce you a little bit of the different kind of high frequency. Then we'll talk about how you optimally use high frequency in an invasive mode, which is the current practice, what we use right now. What's the advantage of using it non-invasively versus what we're doing? And I will review some literature, some of them new, some of them a little bit old, and then maybe we'll come up with some ideas. So if somebody here into fellowship and maybe 4 years from now, 5 years from now, do a study, and then maybe it will become standard practice. So high frequency ventilation, that simple principle of it, we use very high speed or high frequency and a small tidal volume. So in theory, it should not work because you're using a tidal volume less than dead space. So if you're using the same mechanics of gas movement, and you move dead space air into and outside the lungs, you're not exchanging, gas. So that's kind of simple. But because the principle of gas movement in high frequency is different than the conventional ventilation, it will work. So we use constant descending airway pressure, which is pretty much similar or a little bit maybe higher than what we use in the conventional ventilation. And the aim is to reduce the ventilator-associated lung injury. Now, I don't know how much of you, many people like were practicing in 2000. Year 2000 came out where a lot of people thought that high frequency is like a key for the future to reduce lung injury. And at that time, every small baby comes with like, less than 1 kilo. We put them initially on high frequency. And we use it as a initial mode, not as a rescue mode. Then it came back a very known study. It's called the HFV study, which showed that if you do this, you probably save the lungs from what's called VILI, which is the ventilator-induced lung injury, but at an expense of the brain. So they found that those babies have a lot of IVH. So people quickly abandoned that idea and they moved to the rescue mode of the high frequency. Where do we come up with this idea? It's existing in nature. If you see a little bird, hummingbird, they breathe about 250 times per minute at rest. And their lungs are kind of designed that they can do that because they have a parabronchi access to the air. And that's they make them breathing in a non-tidal fashion. Anybody have a dog? Cat? Okay, dog, good. So dogs, when they pant, they breathe very fast. And they pant is not like really excessive, like that. They don't go from normal breathing to gradually increasing the rate. They will go from normal breathing to panting. Panting is high frequency for the babies, for the dogs. Okay, so when I used high frequency initially, we used the jet ventilator. Anybody use the jet ventilator? Very good. So because I said jet ventilator here, nobody know what I'm talking about. But jet ventilator, and I don't know if there's more than one maker of this, but originally it was Bunnell. And Bunnell is like a guy from California who really loved high frequency. And we are in like East Coast in Philadelphia. And if we have a problem with his ventilator, he will have his private jet coming from California to Philadelphia to fix it for us. He stays a couple nights in Philadelphia and he goes back to California. So that's why how is he committed to jet ventilator. The problem with jet ventilator is that you have to have two ventilators because the concept of jet is that you give inspiratory pressure, but you depends on the lung recoil to have the expiratory phase. So there's no active expiratory phase. So that's kind of different than the machine that we use right now, which is high frequency oscillator, which is have active inspiration and active exhalation phase. So our currently used high frequency oscillator have a diaphragm or piston. I don't know you use Sensormedics, but Sensormedics have a piston. Other ones, they have a diaphragm, just kind of let you know. Have active exhalation, have a single control of mean error pressure. It's only use single device. The only problem with that machine is like it's very, first it's very powerful. You have to know what you're doing when you use it. And second of all, it's very noisy. If you put it in a room with other babies, probably you should check the hearing at the endo for the other babies during that. High frequency jet, it's actually you have to use two ventilators because you don't have an active exhalation. You have to have a conventional attached to the jet and you run them together to give a sigh. So that's kind of like become very crowded around the baby space. So, but it's have some advantages of using it in some certain disease. So whatever ventilator we use, we have to understand two things. One, the lung mechanics, of course. Second is the mechanic of the ventilator that you're using. Because I've seen a lot of time when we do rounds in the morning and then maybe on a high frequency, and I look at the numbers on the ventilator and no specific number. And I ask the fellows, what's this number means? They don't really know. So you have to understand, you don't have to have a degree in mechanical engineering to know, but you should know what's the mechanic of the ventilator before you use the ventilator. I have a friend who refused to have a respiratory therapist in their unit because they want the fellows to understand the ventilators. That's a quick way to understand ventilators. Okay, so for most part, we use it as a rescue. I don't have a lot of slides, so I'm gonna just go like rambling a little bit, so because I don't have a lot of slides to, but you can stop me, Dr. Yahya, if I'm going over time. Most of the time we use high frequency as a rescue these days. But there's certain indication that we use it as a first line. One of them is multiple air leaks, and the other one's pulmonary hemorrhage because you use very high MAP. So for the most part, we use it as rescue from failing conventional ventilation. You have to understand a little bit of the lung air flow mechanics when you use the high frequency. So we understand that this, it is a constant descending airway pressure, and you oscillate around up and down the mean. So, but there's some air principles that you make the machine work. So it's what's called radial mixing. Radial mixing is that when you have the spindle of air going in the air, it's not really bulk flow; it's a laminal flow. And you have a collateral ventilation where the alveoli that adjacent to each other, they share the pressure by communicating directly, not through the bronchioles. And you have the coaxial flow where have the simultaneous movement of air in the center of your airway and simultaneously air moving out at the same time. And you have a pendule left ventilation, which is if you have a two alveoli difference in diameters, you have a different amplitude, depends on their time constant, which is the compliance with the resistance. So, this is just I was trained by somebody who's not really in medicine. He was a mechanical engineer when in Philadelphia, which is I did my publication with. So he published a lot of things about machine mechanics, but we don't, most of the time we don't understand the machine that we're using. So just a little bit about lung recruitment, because we try to put the baby on a ventilator and we think that the ventilator will just simultaneously or instantaneously open the lungs. But it's really a dynamic way that you recruit the lungs. So this is of course, a animal model. So if you use this lung with a PEEP of 0, and then you start increasing the PEEP to 4, and then to 10, and then to 20, and then to 30, and then 35, you probably reach the maximum around 35. And then you back off to 30, 20, 10, 4. So if you look at the 4 that we started with and the 4 that we end up with, you pretty much open the lungs with the same pressure, but now you have recruited the whole lung. And this is the concept I try to kind of teach the fellows, because when you put them on a ventilator, especially in a high frequency, you have to recruit the lungs. And if you don't recruit the lungs, it's not gonna work, and the baby will fail and say, oh, the ventilator did not work. But this is really something that we need to know. So when you look at the pressure volume, this is my favorite loop. And when you're looking at a ventilator, is the volume pressure loop. So when we work in the mean airway pressure, we go from closing pressure, which is the down to the opening pressure, and we go up on the pressure grid into a grid into Pmax. Pmax is like when you reach the pressure that you're not going to extend the lungs afterward at all. And that's kind of like where you see improvement in the oxygenation until you get to that point. Beyond that point, if you increase the pressure more, you're going to drop your oxygenation. Then you back off the pressure until you reach somewhere in the pressure curve and the deflation limb into where you are above the opening pressure and above the closing pressure. So you have to know what's the opening pressure and what's closing pressure, what optimal pressure to do lung recruitment. Otherwise, the high frequency will not work. So if you look at this point, using the same pressure, but you're going up and then you're going down and then using the same pressure ultimately, but you expanded the lung at that point fully. And then you kind of using a very low pressure to ventilate the lungs. You have to understand that when you use high frequency, there's a pressure damping. So whatever you do in oscillation in the ET tube is not going to reach the lung as the same. So you have a pressure damping. And then the pressure damping is affected by resistance, by compliance, by the frequency, and by the IE ratio. So IE ratio when some ventilators are fixed, but the newer ventilator are variable, and people don't really have a lot of clear understanding why we use 1:1 or 1:2. I'll give you an example for this. Like when we use 1:1 or 1:2, the frequency, first of all, is inversely related to the total volume. And this is not because the I time and E time. If you ask the manufacturer this, they will tell you this is really not I time and E time. This is just airway resistance part. when you go up on high frequency on the rate, you're creating more resistance if air movement in the airway, and you kind of decrease your tidal volume. And the more like you do it, the less tidal volume you get if you have a 1-to-2 ratio than to 1-to-1 ratio. So if you really want to ventilate babies on a newer ventilator, you have to put them on 1-to-1 ratio. When they get better, you put into 1-to-2 ratio. This is just all the graphs that side by side, you know, the difference between high frequency jet, you don't have a exhalation phase. You have only positive phase. And the high frequency up and down. Okay, so that was so what's the current evidence? Evidence is that basically we're not sure that high frequency will work as a primary mode in RDS yet, but maybe in the future. We don't know if it's going to prevent chronic lung disease in the future. Maybe we'll find some other, but there's one new meta-analysis. I'll show you the results of it. Maybe disputing this point, maybe it will say high frequency can decrease your chronic lung disease. And we don't know if it's really using it as a first line mode. It will be supported by enough evidence at this point. So I don't know if you can see this, but these are like a meta-analysis that's published in Pediatric Research in 2022, which put all the studies that they compared high frequency to conventional. And they group it in 3 groups. One, they use high rate in conventional. One is low rate of conventional, and one they're not sure about what the rate of conventional. When you put them all side by side, you see that high frequency decrease the harmful effect of the ventilator on the chronic lung disease. So decrease the chronic lung disease occurrence. So this is maybe true. We'll need more studies to confirm this. We know that high frequency is, yeah, I'm pretty much done. So increase the CO2 removal. I use it in combination between conventional and high frequency. When I'm stuck, either like I need to do high frequency, but I over-ventilate the baby, or I cannot ventilate the baby even with a higher setting of high frequency. And some people are not comfortable with this, but it's really used and it's very useful. So when we ventilate babies, we need to understand the disease, understand the ventilator, and understand what's the effect of ventilator. So in the last 10 minutes, I'm going to be talking about what's available data for non-invasive high-frequency ventilation. So as I talk about, you know, non-invasive ventilation will follow the same rule as like recruiting the lungs. So you have to recruit the lungs around the pressure, the volume pressure loop. And we have to make sure that you understand that CO2 removal will be very, very rapid. So you have to keep an eye on your CO2 in the babies and your DCO2 in the ventilator if it's measured DCO2, which is the minute ventilation. And we can over-distend the lungs, especially in the high frequency use. The piston is kind of like your car engine. So you can suck the whole lung if you don't do. And I see some respiratory therapists, they put the alarms so liberally because they don't want to hear alarms. So just try to make sure when we're around that to fix the alarms. So why we need non-invasive high frequency ventilation? Maybe we'll decrease the lung injury by invasive ventilation. We know for sure that when you invasively ventilate babies, you induce at least infections because you're taking out the first mechanism of protecting your airway, which is the epiglottis. Maybe you decrease the BPD, maybe not, we'll see. And prevent extubation failure. So we know it's worked in nature. It works in the lab because there's a lung model. If you do a lung model with the computer, and then you see that high frequency will actually have a better CO2 removal than NIFBC and better than nasal CPAP. In animal studies, this is a preterm lamb. They actually remodeling the mesenchymal cell turnover. That's decreasing the lung injury and decreasing PPD in animal lab. It definitely decreases CO2. This is a study on 14 very low birth weight infants ventilated 2 hours with the non-invasive high frequency. And they look at the CO2 at the end of 2 hours, and they found that 2 hours CO2 It's less in most of the babies, except for one. That helps. Nasal high frequency oscillation decreases CO2. This is an TTN. They decrease the length of the disease when you put them on nasal high frequency versus nasal CPAP. They needed less days of being on a ventilator. And this is a not too old studies in 2019, which compared nasal high frequency versus nasal CPAP. And they found actually that failure to intervention, that means the baby needs to be intubated, is less. There's a less all-grade IVH when you use nasal high frequency versus nasal CPAP. And here's the numbers, significant numbers. So in conclusion, does the type of ventilator have impact of nasal high frequency? Of course, you have to have knowledge of the high frequency. Maybe you use the active exhalation, not the passive exhalation when you use, or otherwise you have to use 2 ventilators. Is oxygenation improved with nasal high frequency? In animal study, yes. Is it safe? If you know how to use the high frequency, it's safe. Does it work? In nature, it's work. In laboratories, work. In animal models, work. And in some clinical setting, it's worked. Is it easy application? Our goal is to avoid intubation. Now we're doing all the non-invasive administration of surfactant, non-invasive ventilation. I think we need to have a step up from ventilation if our non-invasive ventilation conventional fails. And we know that it's very effective in CO2 elimination and potentially reduce lung injury. That's in animal models, and they have to be proven in human. If a nasal CPAP is well established, maybe it's additional to be having a nasal high frequency in case the baby's failed.